Hello, everyone. My name is Joseph Titano. I am one of the assistant professors in interventional radiology at Mount Sinai. I'm going to talk about in-stent restenosis treatment options. I have no relevant disclosures for this talk. In-stent restenosis refers to loss of luminal volume within a stent itself or within 5 millimeters of the margin of the stent. There's a classification system that is often referenced in the literature regarding in-stent restenosis, published by Tosaka et al., that distinguishes focal, diffuse, and complete occlusion of in-stent restenosis, with class 3 being totally occluded stents that have shown to be at risk for recurrent in-stent restenosis, occlusion, and requirement of bypass. So the scope of the problem is actually quite broad, with upwards of 20 to 40% of stents occluded within the first year of placement. This incident should be improving with the advent of interwoven nitinol stents like the Supera pictured here, and with drug-eluting stents. Longer stents, overlapping stents, and stent fractures have all been associated with increased risk of in-stent restenosis as well. So with in-stent restenosis, a basic understanding of the pathophysiology involved in the process is actually quite helpful in understanding the approach to this rather troublesome clinical entity. Insertion of a foreign body into an already diseased blood vessel itself constitutes a vascular injury, and the radial force that the stent applies to the adjacent vessel can be unevenly distributed on account of non-uniform plaque distribution, and can cause disruption of the endothelium and small focal dissections. The subsequent inflammation causes a cascade of mediators and growth factors that result in migration of vascular smooth muscle cells and increased extracellular matrix deposition in the intima, as shown here. While the process is complex, the main culprit is the activated smooth muscle cell, which can be seen here in sections from 10 patients with in-stent restenosis. And we'll revisit this process throughout our review of in-stent restenosis interventions. So with the microscopic process in mind, we should consider the mechanics of the lower extremity and their impact on the superficial femoral artery. The torsion, flexion, extension, compression, all applied to the superficial femoral artery containing a stent, can exacerbate this process of endothelial injury and subsequent inflammation. As far as medical management of femoral popliteal stents, there was actually a randomized study, the STOP-IC study, and a larger meta-analysis of over 2,000 patients that did show patients receiving cilostazol had better patency of their stents over a year. And just, again, thinking back to the pathophysiology, this is thought to be related to upregulation of the p53 oncogene, leading to blocked cell cycle progression and smooth muscle cell apoptosis. Many studies that we'll see in the coming slides, they use standard angioplasty as a comparison. However, at this point, it's pretty clear that standard balloon angioplasty is an insufficient treatment for in-stent restenosis as monotherapy. While the optimal treatment algorithm is not yet clearly delineated, standard angioplasty shouldn't really be offered for cases of in-stent restenosis. The explanation for the high recurrence of stenosis and increased need for target lesion revascularization is multifactorial, but the likely explanation is that the intimal tissue is not removed, it is simply compressed with rapid re-expansion after the intervention. So now we're arriving at the workhorse for the treatment of in-stent restenosis, the drug-coated balloon. Use of DCBs is well supported by prospective data, and it's attractive in that it addresses the underlying pathophysiology by inhibiting smooth muscle cell migration and proliferation without the need to leave behind any additional hardware. So the grade patency figures here are actually reported at 6 months and not 12, as the table suggests. In multiple studies, some of which are selected here, DCBs outperform standard balloons in the treatment of FemPop in-stent restenosis, with primary patency rates at 1 year of about 70 to 80%, and with freedom from target lesion revascularization in 85+% of cases. There's one study here of the freeway balloon that had higher incidences of restenosis and target lesion revascularization. This is likely attributable to the fact that they were dealing with longer, more complex lesions in that study, and DCBs did still significantly outperform standard angioplasty. Sorry, this is just a quick list of citations for the studies referenced in the previous slide. So the debate ISR patients were actually followed out to 3 years, at which time drug-coated balloon patients and standard angioplasty patients both required target lesion revascularization at similar rates. This finding, also seen in coronary stenting, is termed the late catch-up phenomenon, which implies that the effects of the DCB don't last indefinitely, and that the forces applied to the stented femoral artery can restart the inflammation process over time. A recently published study comparing DCBs and standard balloons in the treatment of in-stent restenosis also showed similar results, with DCBs being superior in terms of freedom from target lesion revascularization, with a late catch-up phenomenon also suggesting in their data as the rate of target lesion revascularization increased around the 2-year mark in the DCB group. The interesting thing that this group did, aside from choosing a sweet name for their trial, Copacabana, they took patients requiring target lesion revascularization from either arm, and they treated them with a double dose of drug-coated balloon, and then they followed them as a separate subgroup. The double dose was literally deploying additional balloons sufficient to cover the length of the lesion twice. And impressively, there were actually no incidents of target lesion revascularization following the double dose treatment over a mean follow-up of 21 months. Covered stents are an additional option. They do not directly address the underlying pathophysiology, but instead they exclude the restenotic agents and the smooth muscle cells from invading the restored patent lumen. In the Reline study, covered stents outperformed standard balloons in terms of primary patency and freedom from target lesion revascularization at 12 months, with these metrics on par with the results that we've seen in the DCB trials we previously discussed. So atherectomy offers the possibility of removing the expanded intima in order to reestablish a patent lumen. As we will see, while it does outperform standard balloons, atherectomy's monotherapy does not deliver the same patency and freedom from target lesion revascularization as DCBs or covered stents. Again, grade data points indicate values that were assessed at 6 months. Generally speaking, looking at the patency data and the need for target lesion revascularization in roughly 60 to 75% of patients at 1 year, atherectomy has poorer outcomes than the better studied drug-coated balloons. This could be a reflection of the fact that atherectomy alone doesn't address the underlying pathophysiology that is driving the in-stent restenosis, and instead simply provides luminal gain through debulking only. Again, a brief slide for references. So since we saw the effectiveness of drug-coated balloons in treating in-stent restenosis, it's reasonable to consider drug-eluting stents in the same clinical context. Zeller et al., they looked at a subset of 108 patients in the Silver PTX study who had bare metal stent restenosis that was treated with drug-eluting stent placement. And indeed, the primary patency and freedom from target lesion revascularization were comparable to those seen in DCB trials, although the drug delivery from a paclitaxel-coated stent is likely advantageous in the restenotic setting. Many proceduralists these days would argue that you could probably achieve these results with drug-coated balloons without the need for additional implants. So given everything that we've seen about the various options for addressing in-stent restenosis, it makes sense to consider possible synergistic effects of these interventions. In the salvage study, the combination of excimer laser and covered stents were evaluated, And the combination therapy showed a freedom from target lesion revascularization at 12 months in about 83% of cases, which is impressive considering that the mean lesion length in this study was greater than 20 centimeters. The theory is that the excimer laser ablation of the neointima allows for optimal expansion of the covered stent. Gandini et al. Also evaluated the combination of laser atherectomy and drug-coated balloons compared to just drug-coated balloons alone. And they found that 2/3 of the laser plus DCB group demonstrated primary patency at 12 months with freedom from target lesion revascularization in 83.3% of patients, which is impressive in this study, given that the cohort was drawn from patients with CLI and Tosaka 3 complete stent occlusions. The thinking here is that the debulking with the laser atherectomy allows for more homogeneous paclitaxel uptake in the vessel wall, which thereby improves patency. No specific algorithm exists for choosing treatments or treatment combinations, but the armamentarium for addressing in-stent restenosis has grown considerably over the last decade. So to summarize then, in-stent restenosis is driven by vascular inflammation and smooth muscle cell migration and proliferation that is exacerbated by the forces applied to the SFA. It's unfortunately common. Drug-coated balloons and covered stents are probably better monotherapies than standard angioplasty, cutting balloons, or atherectomy. And there are combination therapies available that address the pathophysiology involved in the underlying disease process. Thank you, everyone. Enjoy the rest of the summit.